So I don't know how this video is actually going to come out because I'm still recovering from my flu, not really 100% recovered. So my voice may sound a little bit fluish. So I don't want anyone in the comments saying, oh, why does your voice sound different? All that stuff. I've already explained that here. So this is a video that I've been wanting to do for a very long time. And I realized that most of the information that we have on YouTube and most of the content creators that are actually making videos in relation to this either make a video that has just basics and it's not really so practical in real life, or someone will give you something that is too complex and overloads you with a lot of information at once. There's no one who has a balance with practical things and things that you really need to know in terms of passing your exams and in terms of actually having a baseline to start off your renal lectures. And I haven't done a lot of renal lectures on my channel. This is why I actually decided to come up with this particular video to discuss renal topics. This is a video that is important for internal medicine, and I'll also leave it in the emergency medicine playlist. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at acute kidney injury. If you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, let's go. So remember that the kidneys in your body are going to be serving many different functions. They serve as an organ that is important for removal of waste materials. They participate in the process of glucose metabolism. They also participate in the absorption of certain electrolytes such as calcium through the action of vitamin D, which gets activated in the kidneys. So the kidneys are very, very important. This is why you have two of them. So when there's a problem with the kidneys, this may lead to certain derangements, and these problems could either occur acutely. Most of them that are occurring as an acute thing are going to be lasting less than 3 months. If it's a problem that is lasting more than 3 months, then you're thinking that this is a chronic thing. But then you may also have a bracket of patients that may have an acute on chronic presentation. So when we talk about acute kidney injury, way back it was referred to as acute renal failure, but no one calls it that because acute kidney injury is going to encompass a broader term or broader aspect of different conditions, a spectrum of different conditions. So here you're going to have this sudden and often reversible reduction in renal function or glomerular filtration rate. Remember that each and every minute, each and every second, each and every hour, blood is reaching the kidneys for the purpose of it being filtered out. This blood that is reaching the kidneys and that is being filtered out at a certain rate in the glomerulus is known as the rate at which this is happening. You call this is the glomerular filtration rate, which of course is going to be greatly regulated in the kidneys. And if this has failed because the renal function has declined, this is going to result in an increase in the creatinine, in an increase in the serum blood urea nitrogenous waste, as well as a diminished urine output. But this may not actually even occur immediately. You may not see the rise in the BUN, the blood urea nitrogenous waste. You may not see a rise in the creatinine, and they may still remain in the normal levels despite someone still having an acute kidney injury, an AKI. So the only thing that's going to be quite important in terms of picking out that this person has an AKI is going to be a diminish in the urine output. And remember that these patients are going to have this rapid reduction in this renal function that's going to be occurring sometimes within hours, sometimes within days, and they're going to have this elevation in the serum urea, elevation in the creatinine, and this is going to lead to them being unable to maintain the fluid balance, to maintain electrolyte balance, as well as acid-base homeostasis, which is an important function of the kidneys. AKI is a very common condition that affects up to 7% of the hospital admissions and 70% of patients with ICU admissions. And remember that once someone now has this AKI, they can no longer excrete that excess water from the body. They can no longer excrete that excess sodium from the body. They can no longer excrete that excess potassium from the body. So these things, together with the metabolic waste, begin to accumulate into the bloodstream, and this is what's going to be causing problems for your patient. Some normal values that I want you to keep in mind. Remember that the normal urine output is about 0.5 to 1 mils per kg per hour. So it means that if someone is weighing 70 kgs, it means that 70 multiplied by 0.5, that's 35. 70 by 1 is 70 rather. So in 1 hour, this person must produce between 35 to 70 mils in 1 hour. Then the normal creatinine is between 53 to 106 millimoles or micromoles, so it should be micromoles per liter. Then the females is 44 to 97. Of course, you can change this to milligrams per deciliter, but I'm using these units because these are our standard units in our country. So the normal urea is 2.5 to 7.2. So some important terms I want you to keep in mind: azotemia and uremia. The difference is this. So in both of these conditions, you're going to be having increase in nitrogenous waste. You're going to be having decrease in renal function. Now with azotemia, you have these nitrogenous wastes that are accumulating in the blood whilst the patient doesn't have any symptoms. So meaning that if you look at the GFR of this patient, it's about 20 to 35% of the normal. Whereas with uremia, there is a reduction in the renal function and there are symptoms. I will talk about some of these symptoms of uremia, because remember, uremia is one of the indications for dialysis. Here in these patients that have uremia, the GFR might be less than 20% of the normal. Anuria is a urine volume less than 100 mils per day. They're not producing urine at all. Oliguria is a urine volume that's less than 400 mils per day. There are different organizations that actually classify AKI in different ways. One major classification or criteria is known as the Kidney Disease Improving Global Outcome. That's the KDIGO, which I will talk about a lot in detail. Then this is the most commonly used, but we have other things like the RIFO criteria. RIFO is an acronym for risk, injury, failure, loss, and end-stage kidney disease, and the AKI, which is the Acute Kidney Injury Network, which you can sometimes think of as a modified type of RIFO criteria. All these criteria have similar predictive abilities in terms of in-hospital mortality, so no one is superior to the other, but commonly used, and the one that I want you to remember is the KDIGO classification or KDIGO criteria. So how does the KDIGO actually define AKI? So 3 things. The easiest that I want you to remember is urine output, because it's very quick for you to do even in the patients that are on your ward. So anyone with a urine volume that's less than 0.5 mils per kg per hour for at least 6 hours in adults or 8 hours in children, we say that they have AKI. If they have an increase in the serum creatinine by 0.3 milligrams per deciliter or more than 26.5 micromoles per liter, within 48 hours, we consider this patient to have AKI. Or if they have a serum creatinine that has increased more than 1.5 times or more from the baseline from the prior 7 days, we say that the patient has AKI. So if your patient is fitting any of these 3 criteria, you're going to say that your patient has AKI. Now, you can stage the AKI. So stage 1 is if they have an increase in creatinine between 1.5 to 1.9. Stage 2 is between 2 to 2.9. Stage 3 is more than 3 times increase from the baseline. So what I want you to remember, stage 1, it's 1.5. Stage 2, it's 2. Stage 3 is 3 times increase. And out of this, remember, these patients are going to require urgent emergency referral to a hospital that has a renal unit and is capable of performing renal replacement therapy. Remember, in terms of renal replacement therapy, 3 things are involved. It's either the patient is going to have a renal transplant, or the patient is going to have hemodialysis, or the patient is going to have peritoneal dialysis. The quicker of the 3 to do, of course, the dialysis, the hemodialysis or the peritoneal dialysis, depending on whoever is present at that facility and whoever is able to carry out these procedures. So all the patients with stage 2 and stage 3 AKI need renal replacement therapy, so they need to be taken to a hospital that has these facilities. They need to be hospitalized. Patients that have stage 1 with an unknown duration of serum creatinine, it's an indication for hospitalization. Those with heart failure, exacerbation, or those with DKA, or those with sepsis, or any other medical condition, make sure that you admit these patients, and you should actually urgently refer them to a hospital that has and can provide them with treatment. That's a renal replacement therapy. If you're in a place where it's resource limited and you know that now this patient may go into AKI, you don't have the facilities to help this patient, refer this patient early on before things get worse. Then in terms of the RIFO criteria, it's divided into 3 levels of renal dysfunction or renal impairment. That's the risk, injury, and failure. And then 2 outcomes, that's the loss and the end-stage renal disease. In terms of risk, anyone with a creatinine 1.5 times the baseline, you can think of this kind of like KDIGO stage 1, or 25% of the GFR, or the urine output less than 0.5 mils per kg per hour for 6 hours, we say that they're at risk. Then those that have undergone injury are those that have creatinine 2 times greater than the baseline, or 50% of the GFR reduction, or urine output less than 0.5 mils per kg per hour for about 12 hours. We say that they have injury. For those that have failure, is a 3 times rise in the baseline, or 75% GFR reduction, or creatinine equal or greater than 4, or a urine output less than 0.3 mils per hour for 24 hours, or if they're anuric for 12 hours, we say that they are in failure. Then the long-term outcomes, if there's loss of kidney function over 4 weeks, that's 1 month, they have loss. And then end-stage renal disease, anyone who has loss of function over 3 months. These are the patients that are going to be having your chronic kidney disease. So remember, whichever criteria that shows the most important impairment is going to be used for the classification. Or the most impairment is going to be used for the classification. If you don't know the creatinine of the patient, you assume that our baseline GFR is between 75 to 100 mils per minute, and this is assumed, or sometimes we may use a modification of the diet and renal disease equation to actually calculate an estimated baseline creatinine. Remember that the acute kidney injury network criteria, like I said, is based on the RIFO criteria. Some people actually refer to it as the modified RIFO criteria, but I didn't include it in this particular lecture because I want you to focus pretty much on the KDIGO. So there are some risk factors that are involved in developing AKI and age above 75, those patients with cardiac failure, those with peripheral vascular disease, those with chronic liver disease, those with diabetes, those that are on drugs, especially if they're newly started. There are some drugs that can cause or worsen AKI, NSAIDs, ACE inhibitors, ARBs, antibiotics, especially the aminoglycosides, vancomycin. Those are some of the drugs that can cause AKI and worsen AKI. Sepsis, it could be poor fluid intake or increased losses, which could be related to GIT losses. It could be a history of urinary symptoms. These are all risk factors for developing AKI. Now, here I want you to pay very close attention to this principle because it's going to help you somewhat distinguish between pre-renal, intrarenal, and post-renal AKI. So, although clinically this is not so helpful, but in terms of your exams, this actually may be quite helpful. So remember that the blood is going to be reaching the kidneys and it's going to be filtered out via the renal artery. So once this blood reaches the kidney, it enters through the renal artery. This blood has waste materials that need to be filtered out. It has excess water, it has excess electrolytes. So this blood is going to pass through or enter into the glomerulus via an afferent arteriole. And then the glomerulus has a basement membrane. It has a filtration membrane that is specialized to filter out excess water and filter out excess electrolytes. So some of the electrolytes are filtered out into the renal tubule. And then some of these electrolytes and fluid that is filtered out, some of it can get reabsorbed back into the bloodstream. We refer to this as tubular reabsorption. Some of these electrolytes that are in the filtrate are going to be left in the filtrate. Then the renal tubules can also secrete other electrolytes into this filtrate. We call this as tubular secretion. So the ultimate filtrate that is left into the renal tubule is what is going to reach at the end as urine. So in essence, urine is going to be pretty much the glomerular filtration minus the tubular absorption plus the tubular secretion. Whatever is going to end up in the renal tubules at the end is what is going to be responsible for the urine that you're going to produce. Now remember that one of or two of the waste materials that are excreted in the urine are urea and creatinine. In terms of the reabsorption, urea can be reabsorbed back into the bloodstream. In terms of creatinine, very little, sometimes even no creatinine is actually going to be reabsorbed back into the bloodstream, such that we can actually use the ratio of blood urea nitrogen to creatinine in the bloodstream to actually judge and actually give us an idea of how good the renal function is. So the normal BUN to creatinine ratio is roughly about 5 to 10. So what does this mean? It means that for every 5 to 20 molecules of BUN that are reabsorbed, you reabsorbed 1 molecule of creatinine. So it's like 20 to 1. 20 molecules of BUN are reabsorbed, and only 1 molecule of creatinine is reabsorbed. So problems that can affect the nephron can affect this BUN. They can affect the blood urea nitrogenous creatinine ratio. It can either increase or decrease. I'll talk about them in detail when we come to look at the different types of renal injury, whether it's pre-renal, intrarenal, or post-renal. I want you to keep this concept in mind. If you don't understand, pause the video, rewind, and make sure that you understand this concept before moving forward. So remember, like I said, ultimately, whatever has remained inside the renal tubules is going to reach at the end of the kidneys, and that's what's going to be urine, and it's going to pass through the ureters into the bladder, and then from the bladder it's going to be passed out to the rest of the body, or rather outside the body. And then the blood is eventually going to be draining into the renal vein, and that's how filtration is working inside the kidneys. There are some things that can affect the concentration of urea and creatinine in the blood. So things that can cause a decrease in the levels of urea. Remember, urea is coming from protein breakdown, protein metabolism. So those that have low protein intake, those with liver failure, those that are taking sodium valproate. It can be increased by patients that are on corticosteroid treatment, those that are taking tetracycline antibiotics, those that have GIT bleeding could increase levels in urea. Creatinine mostly is highly concentrated in the muscles, so it has to be something to do with the muscles that can alter its concentrations. So anyone with a low muscle mass will have decreased level of creatinine. Those that have increased muscle mass, those that eat red meat, a lot of red meat because it's highly concentrated in muscles, those that undergo any muscle damage, rhabdomyolysis. If there's anything that is competing with the secretion of creatinine, remember creatinine is going to be secreted by the renal tubules, but then if it's competing with something else that is going to be secreted in the renal tubules, some of the creatinine remains in the bloodstream. This can be seen with cimetidine, which is an antihistamine. It can also be seen with trimethoprim. In terms of acute kidney injury, we largely divide it into 3 main groups. This is very important because you should be able to distinguish between these 3. The management is going to be different from each of these 3. For example, if you get a pre-renal patient versus an intrarenal patient, if you give fluids to this patient that has pre-renal failure, they may improve. If you give fluid to a patient with intrarenal failure, they won't improve, they may actually worsen. So it's very important to know the difference between these 3 conditions. Most of the cases of AKI that you're going to be seeing are pre-renal in nature, meaning affecting the blood flow or the blood supply to the kidneys. These are accounting for about 40 to 70% of the cases. This is later followed by intrarenal causes, 10 to 50%. Some of the pre-renal causes can actually progress and cause intrarenal failure. Then post-renal is often due to obstructions. It accounts for about 10 to 25%. So we'll begin with pre-renal failure, or pre-renal AKI. So here there's a reduction in blood supply to the kidneys. This is the most common type of AKI, 40 to 70%. So this could be either in the background of someone not having their kidneys perfused because there's systemic hypoperfusion, there's something that's causing them to be hypotensive. Or maybe it could be due to certain things that are just affecting the kidneys and affecting the perfusion of the kidneys. For example, they have a renal artery stenosis or they have an aortic dissection. Now, remember, here there's no problem in the kidneys. Of course, if the problem is persisting, you may actually cause some damage and some necrosis to happen to the renal tubules, but here the problem is not in the kidneys. So remember that the kidneys here have the normal function. It's just that they are receiving less blood. So even though the patient may actually be hypotensive, the kidney blood flow may not be consistent, and there may be wide variations inside the blood pressures, actually the amount of perfusion that reaches the kidneys and even the volume status that's reaching the kidneys is strictly regulated in a mechanism that we call autoregulation. Now, if you still are not supplying enough blood to the kidneys, this autoregulation mechanism can actually fail. And once this autoregulation mechanism fails, it means that these kidneys are not going to be receiving less blood. If these kidneys are going to be receiving less blood, it means less blood is going to be filtered out. And remember, if this blood is not being filtered out, it means that your GFR is reducing, your glomerular filtration rate is reducing. And there are certain sensors inside the kidneys, because remember, the nephrons are working well at this point and not damaged to any extent. So there are some sensors in the body that are going to sense that, okay, you're filtering out less things, whatever is reaching these sensors is becoming quite concentrated, so it will trigger your renin-angiotensin-aldosterone system and ADH system. So you're going to be retaining a lot of sodium, you're going to be retaining a lot of water. And remember, the kidneys are not being perfused, GFR is reduced, meaning that the filtrate that you have in the renal tubule is reduced, the amount of urine that you're going to be producing is reduced. And of course, because there is no cell injury, you tend to reabsorb some of those electrolytes, you reabsorb a lot of this water until you can make up for the little blood flow that is there to the kidneys. If you restore the perfusion, of course, the function of the kidneys often is going to return. But if the injury that has been there remains, you may actually result in a type of necrosis that's known as acute tubular necrosis, which is a type of intrarenal AKI. So like I said, pre-renal could sometimes progress to intrarenal injury. So remember what I told you about earlier on? I say that for every 5 to 20 molecules of BUN, you are going to reabsorb 1 molecule of creatinine. And remember what's happening in pre-renal AKI. You have something that is decreasing the blood flow to the kidneys. This is resulting in a reduction in the GFR. And this means that less things are going to be filtered out inside the renal tubule. There's going to be less fluid filtered out inside the renal tubule, less urea, less creatinine. Most of it is remaining in the bloodstream. Now, the sensors in the kidneys, the juxtaglomerular apparatus senses this and triggers that renin-angiotensin-aldosterone system, the cascade. And this is going to trigger release of those hormones to reabsorb most of the water, reabsorb most of the sodium. And in the process, remember here we say that urea can be reabsorbed, creatinine can't. So it means that as you are reabsorbing the water, as you are reabsorbing the sodium, you end up also reabsorbing the urea. So you have even more urea actually accumulating inside the bloodstream, such that if you look at your BUN to creatinine ratio, it will be greater than 20:1. It will be greater than the normal. So because you're now reabsorbing a lot of the sodium from the renal tubule, it means that less sodium is actually going to be excreted from the urine. If you actually test the amount of sodium in the urine, there'll be less. It'll be very low, less than 20 millimoles per liter, because the tubules are functioning. They're okay. They're not yet injured, and you're reabsorbing some of these. You're reabsorbing some of this sodium. You may actually increase the sodium in the urine if you administer diuretics or dopamine to these patients, though the evidence here in most of the clinical trials, especially those that aim to actually convert non-oliguric type of AKI to oliguric, or rather the oliguric to the non-oliguric type, there's been some scanty data on that, and generally most of the trials actually don't even advise for you to do this. Then there is something that's known as a fraction of excreted sodium. So it's just simply the ratio of the sodium clearance, meaning the amount of sodium that is excreted divided by the amount of sodium that is filtered, to the ratio of creatinine, meaning that the fraction of the creatinine that is excreted divided by the fraction of the creatinine that is filtered is often going to be less than 1%. Because most of the sodium is being reabsorbed, a lot of the creatinine is not being reabsorbed, meaning that the tubular function is normal. There's no damage to the tubules. So the fraction of excreted sodium is going to be less than 1%. It's going to remain low in some of the cases of intrarenal AKI, like for example, those that have contrast-related nephropathy or myoglobinuria. And because now you're reabsorbing some of this sodium, you're reabsorbing water, you're reabsorbing the urea, the osmolarity, the urine becomes very concentrated because you reabsorb a lot of this water. So the osmolarity is going to be greater than 500 milliosmoles per kg. And this also does indicate that the functioning of the renal tubule is still normal. The urine specific gravity, which is the ratio of the density of the urine compared to that of water, is going to be increased, greater than 1.02, because you have a lot of electrolytes that are ending up there that are not being reabsorbed. And this urine is very concentrated, it's very dense. Because you're reabsorbing some of this water, this patient is going to have oligurias. So they're going to have a urine output less than 400 mils per day. So this is how you're going to be calculating the fraction of the fraction of excreted sodium. So the amount of sodium in the urine divided by the plasma concentration of sodium plus the concentration of creatinine in the urine divided by the concentration of creatinine in the plasma, multiply that by 100. If it's less than 1%, it's most likely pre-renal. If it's more than 1%, it's most likely intrarenal. And remember what is happening in pre-renal. You have these electrolytes, water being reabsorbed, sodium being reabsorbed, so less of it is reaching in the urine, so it's less than 20 millimoles. And then, of course, the urine is very concentrated because a lot of the water has been reabsorbed and the specific gravity has increased. This is quite different from intrarenal problems where there's actually a problem with the nephron. It fails to reabsorb the sodium, so most of the sodium remains inside the urine, greater than 40. It fails to reabsorb the sodium and the creatinine. They end up in the urine, greater than 1% ratio. Then, of course, because you fail to reabsorb the water as well, because there's a problem with the nephron, the urine is not as concentrated. It's actually quite dilute, less than 350 milliosmoles per kg, and a specific gravity that is less than 1.01. What are some of the causes of prerenal AKI? Think of it like this. It could be hypovolemic related, things that are causing hypovolemia, anything causing hypovolemia, severe burns, hemorrhage, GI losses like diarrhea and vomiting, very common among patients that incur a lot of losses in acute gastroenteritis. For example, those patients that are suffering from cholera. You have those that have high osteotomy outputs, like those that with colostomies, ileostomies that are putting out a lot of fluids. Renal losses, like those patients on diuretics or osmotic diuretics, those patients that have diabetes mellitus, hypothyroidism, third spacing, for example, a pancreatitis, a peritonitis, trauma, burns, and even severe hypoalbuminemia. It could be due to patients having low BPs because they have a problem with their cardiac output. They have a problem with their cardiovascular system. There's some form of cardiovascular failure. Could be diseases of the myocardium, like a dilated cardiomyopathies, diseases of the valves, even of the pericardium, an arrhythmia, a tamponade, cardiogenic shock, congestive heart failure, and other things like massive pulmonary embolism, acute coronary syndromes, and even pulmonary hypertension. It could be due to some vasodilatation. So the problem could be coming from the heart, or it could be associated with the peripheral blood vessels. They're just dilated and less blood is actually reaching the heart. Therefore, remember, with your Frank-Starling phenomenon, this means that less cardiac output coming from the heart, less perfusion to the kidneys. So this could be in the background of a septic shock and anaphylaxis. Even this happens with anesthesia administration. Or indeed, it could be constriction of the vessels inside the kidneys or dilatation of the vessels inside the kidneys. Remember that there's an artery that is feeding the glomerulus, which is known as the afferent arteriole, afferent. Then you have the glomerulus, which has this network of capillaries. Then you have the efferent arteriole, which is removing blood from the glomerulus. So if there's anything that is going to cause vasoconstriction of the afferent arteriole, this is going to affect the GFR. This is seen with NSAIDs, which tend to produce, or rather block the production of prostaglandins through the blocking the production of prostaglandins through blockage of the cyclooxygenase enzyme. So this causes arterial vasoconstriction, especially with the afferent arteriole, such that even now the GFR is going to be affected. The pressures will be very high. This can cause damage to the glomerulus. This can also be seen with iodinated contrast. It can also be seen with amphotericin B, calcineurin inhibitors, and even hepatorenal syndrome. Then it could sometimes be occurring with vasodilatation of the efferent arteriole, where it's like the pressure is now greatly reduced. You have the efferent arteriole being not so much affected as much as the efferent artery. You have the efferent artery being dilated so much such that the pressures in the glomerulus are very less, filtration is actually less. So there's intraglomerular hypotension. This is seen with ACE inhibitors and angiotensin receptor blockers because they'll block the action of angiotensin binding to its angiotensin receptor, so they'll cause vasodilatation in the efferent arterioles. It could be sometimes some vascular diseases that are limiting the blood flow to the kidneys, like a renal artery stenosis, vasculitis, accelerated or malignant hypertension, cholesterol embolism. It could be a microangiopathy in the background of a hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, preeclampsia, and even a DIC, or sometimes it could be a crescenteric glomerulonephritis. So those are the causes of pre-renal failure, the most common cause. We'll come to talk about diagnostic approach and management at the end of this particular lecture. I really hope you're enjoying this particular video. If you are and it's making sense, please hit the subscribe button and comment in the section below. It actually goes a very long way, and it's actually quite encouraging to make these videos. Apologies if this video is actually very long. Then in terms of intrarenal failure or intrarenal AKI, remember that this is going to be accounting for roughly about 40% of all cases of AKI. Then remember, this damage could either be occurring to three important things, and this is how I want you to think about it. It could be affecting the tubules, so we call that as an acute tubular necrosis. This could be actually progressing from a pre-renal failure or a pre-renal acute kidney injury to it becoming an intrarenal acute kidney injury. Then it could affect the glomerulus itself. There's a group of diseases known as glomerulopathies. One that I want you to keep in mind is glomerulonephritis. Or it could be affecting the interstitium, what is so-called acute interstitial nephritis. In terms of the acute tubular necrosis, or the ATN, remember here that there's necrosis of the epithelium, which is going to be lining the tubules. This is the most common cause of intrarenal AKI. Now remember, unlike with the pre-renal type, the tubules here are being affected. So these tubules are either being killed off by certain toxins, we call that as a toxic type of acute tubular necrosis, or they're being killed off by ischemia, we call that as ischemic tubular necrosis. Whatever is happening here, we have these necrotic cells that are dying, and remember, they begin to shed off. They end up in the tubule. Some of them can actually get to the end of the urine. When you actually look at the urine, you get this brown granular casts in the urine. So these are often actually seen in about 75% of the cases. So you get these renal tubule cells that have been shed off, that are dead, that are in the renal tubules, and they can actually increase the pressures in the renal tubule. And this pressure could be exerted on the glomerulus such that now there's less filtration coming from the glomerulus. And remember, with less blood being filtered out, this means it's going to translate into oliguria. It means that less urea will be filtered out from the bloodstream, less creatinine is going to be filtered out in the bloodstream. These nitrogenous waste accumulate, resulting in azotemia. And remember here, the problem is that the renal tubules are affected. The renal tubules are dying. The reabsorptive capacity and even the secretory capacity of the tubules is affected. So you get some electrolytes being built up in the body, like hyperkalemia, and some acids begin to accumulate, causing a metabolic acidosis. Because now the tubules are dysfunctional, less blood urea creatinine is reabsorbed, so it means that the creatinine, the BUN to creatinine ratio will be less than 15.1. Then of course there's a decrease in reabsorption of sodium, so the fraction of excreted sodium will be greater than 2, and the kidneys themselves will be unable to concentrate the urine, so the urine will be actually quite dilute, though this patient may be oliguric. Sometimes because of this shedding off, this bleeding from the glomerulus that may be happening, especially with the acute interstitial nephritis, you may sometimes get some hematuria and even some proteinuria because you're damaging the glomerulus. So here, if the underlying cause is actually addressed, they may actually recover, but the recovery takes some time because you have to regenerate those renal tubules, so it can actually occur over a few weeks. The patients with ATN are going to cycle through three stages. There's what's known as an azotemic stage, which could either be oliguric or non-oliguric. It's usually oliguric in the early stages, then becomes non-oliguric because now as the kidneys are actually regaining their function, the last function to return for the kidneys is actually the ability to concentrate the urine. So it means that when they enter into this diuretic or polyuric phase, when the kidneys now are beginning to heal, they won't have that ability to concentrate the urine. So it means that they'll still keep losing a lot of water in the urine. They'll actually become polyuric. So there may also be increased osmotic load from the renal toxins that have accumulated, and this can actually lead to massive polyuria. We often want to replace these fluids with the IV fluids. Then in the recovery phase, it can take about 7 to 21 days, though it can actually even be longer in patients with sepsis. This is because the GFR may remain low whilst the urine output actually increases, sometimes to even several liters a day, because of this defective tubular reabsorptive function of these nephrons that are healing. Then the clinical course is rather variable, and it can actually even last up to 6 weeks, even after a relatively mild or even short-lived initial insult. Then eventually the function will return, but it will return to almost normal, even near normal. Sometimes even can be actually normal, except if the patient has had renal corticonecrosis. If they have had renal corticonecrosis, then this may create other problems. There is no treatment that has been shown to lessen this duration of this healing happening. There are some people that have suggested that the use of mannitol, furosemide, or even renal dose dopamine, that's between 1 to 5 micrograms per kg, can help, but actually evidence supporting this is actually weak, and we do not recommend actually using these medications. So like I said, the two common causes of ATN, ischemic and nephrotoxic. So these are part of intrinsic renal failure. It could either be affecting the glomerulus, we call that as the acute tubular necrosis, or it could be affecting the interstitium, we call that as the acute interstitial nephritis, or it could be affecting the glomerulus itself, which could be, of course, your glomerulonephritis, the basement membrane. So in terms of ischemic type, this one here may follow the prerenal azotemia. So the same causes of prerenal azotemia, the hypovolemia, the low cardiac output, the renal vasoconstriction, the systemic vasodilatation. These are the things that I mentioned earlier on. I'm not going to repeat them. They can also cause ischemic acute tubular necrosis. The part of the nephron that's going to be affected in the ischemic type is particularly the proximal tubule, but it can also affect the medullary segment of the thick ascending limb. Particularly, those are the two parts that are susceptible to damage. In terms of nephrotoxin, remember that these are toxins that are accumulating, and certain parts of the kidneys are susceptible to being damaged by this injury, especially the proximal tubule. So it could be drugs, aminoglycosides, very notorious, heavy metals like lead, platinum derivatives, lithium. It could be myoglobinuria, myoglobin, and even hemoglobin are quite toxic. So in patients that have falciparum malaria, those with black water fever, those that have crush injuries to the muscles, rhabdomyolysis or electric burns, which are releasing a lot of this myoglobin into the bloodstream. In children, a very common thing to cause poisoning is ethylene glycol, which is antifreeze. It's this blue, quite sweet tasting solution that you may find in the garage. Then you find the child is just drinking it, and it's quite sweet. The child will keep drinking. So the child is going to develop these oxalate crystals in the urine as a result, and actually this risk of poisoning is quite significant in children. Sometimes it could be in the background of the radioiodine contrast or radioiodated contrast. And remember, this is maybe in the background of a patient that needs a contrasted study like a CTPA. For example, they have a pulmonary embolism. They need a CT of the pulmonary artery. You have to give them contrast. Now, this creates a problem because you know that the contrast can cause AKI or can worsen AKI. So suppose someone has a myocardial infarction and we need a contrasted study, and you know that giving them contrast would be contraindicated. So in this case, you make sure that you rehydrate the patient before you give them the contrast and rehydrate them after the procedure of the contrast. Then in terms of ureate, it could be tumor lysis syndrome or with cancer treatment. Remember, you want to hydrate them, give them allopurinol, and urate oxidase are actually used to give these patients prior to them receiving chemotherapy, because this is going to kill a lot of cells, damage a lot of macronutrients in these cells, and ultimately produce a lot of these toxins. And remember that this is going to be rehydrating them before actually reduces the risk of urate-induced acute tubular necrosis. Then in terms of glomerulonephritis, this is inflammation affecting the glomerulus. It could be in the background of a patient having several other conditions. This is a topic on its own, which I'll cover in another particular lecture on the renal topics. Remember, here you have an antibody and an antigen, forming a complex. These can actually deposit in the glomerular tissue, and this can actually going to be activating the complement system. Some cytokines are going to be produced, leading to macrophages coming to that area, and neutrophils coming to that area that end up producing certain lysosomal enzymes that are going to be causing inflammation and actually damaging the podocytes. These are the cells that are going to be lining the glomerulus. Remember that the filtration barrier inside the kidneys is a barrier to size, meaning anything that is larger than the filtration slits cannot pass through, and is a barrier to charge. It has at physiological pH and physiological conditions, it has a negatively charged property. So meaning that anything that is negatively charged will not be filtered out, which makes the reason why albumin is quite a small molecule but still doesn't get filtered out from the kidneys because it's negatively charged at physiological conditions. So this prevents the large molecules from being filtered out, as well as those that are highly polar, the negatively polar molecules. So when this membrane actually gets damaged and the permeability actually increases, it means some of these molecules can leak out, leading to things like proteinuria, leading to things like hematuria. And this leakage means that now the pressures or the pressure gradient or the ultrafiltration that's supposed to happen in the glomerulus is going to be affected. So it means that the GFR effectively is going to reduce because of this leakage, and it means that lower GFR means that less blood gets filtered, so less urine is produced. They develop oliguria, and more of the fluid remains in the bloodstream. They may develop edema. They may sometimes develop hypertension because of this excess fluid that is actually in the bloodstream, and then these nitrogenous wastes are going to accumulate, resulting in azotemia. And in terms of acute interstitial nephritis, remember that this here is going to be inflammation affecting the interstitium. It can happen over a course of days to weeks, and remember it's going to involve two types of cells. It's going to involve neutrophils, it's going to involve eosinophils. Eosinophils are very important to distinguish acute interstitial nephritis from most of these other conditions, because you tend to see a lot of these eosinophils in the bloodstream. You get to see a lot of these eosinophils actually being excreted in the urine. So it's actually thought to be either a type 1 or a type 4 hypersensitivity reacting to certain drugs like sulfur-containing drugs, beta-lactams or penicillins, NSAIDs, traditional medications, diuretics, infections like pyelonephritis, infiltrative conditions like sarcoidosis, lymphomas, as well as leukemias. In the early phases, you may get oliguria and a lot of eosinophils in the urine, eosinophiluria, very difficult word to actually pronounce. And of course, you may have general symptoms like fever as well as a rash. Here, if you stop the causative agent, then they may actually recover. But if this persists, the immune cells are actually going to damage the cells even further, damage the interstitium, and this may actually kill off the kidney cells and they begin to die. You may actually develop a renal papillary necrosis or necrosis of the renal papillae. This may result in hematuria as well as flank pain. There are other things that may cause renal papillary necrosis. An important cause I want you to keep in mind is sickle cell. You may also have analgesia like aspirin, diabetes, as well as pyelonephritis. Remember here, the nephron is also being damaged here. So there's less reabsorption from the renal tubules, less urea stays in the blood or is reabsorbed back into the blood in relation to creatinine. So the BUN will be less than the normal. Less sodium will be reabsorbed, so the urine will have a lot of sodium, so concentration greater than 40 millimoles per liter. The fraction of excreted sodium will be greater than 2%, and since the water is not reabsorbed, the osmolarity actually is less than 350. Most of the urine will be diluted. Then the last bit is the post-renal AKI. This is due to obstruction. I won't go into a lot of detail of this because it's mostly a surgical or uro condition. So here you actually have to consult the urologist. So here the uremia is going to be resulting because there's an obstruction at any point, starting from the calyces to the external urethral meatus. Then this is going to cause dilatation of the tract above the obstruction, and the dilatation of the renal pelvis is what's known as the hydronephrosis. You can actually do this on ultrasound and see this on the ultrasound. Remember that obstruction, which is intrarenal, which is, for example, in the tubules, actually could include the collecting ducts or even the extrarenal, the renal calyces up until the urethral meatus, and this actually causes a backflow of the filtrate, causing this pressure on the glomerulus, reducing the GFR. So they may have these lower urinary tract obstruction symptoms, things like suprapubic and even flank pain, or symptoms of bladder dysfunction, things like hesitance, urgency. There is a decrease in outflow that results in the decrease in the GFR, azotemia, as well as oliguria. In the early phases, remember that the increase in pressure on the glomerulus will force some of the urea back into the bloodstream. So in the early phases, it's actually quite similar to a pre-renal AKI, because again, the functioning of the renal tubule is normal. So it means that your BUN to creatinine ratio will be greater than 15. Your tubular function will be okay, so the sodium will be reabsorbed and the fraction of excreted sodium will be less than 1%. Urine osmolarity will be greater than 500 milliosmoles. But with long-standing obstruction, less GFR, less reabsorption of urea, the BUN to creatinine ratio in serum was less than 15 to 1. There's decrease in the reabsorption of sodium, so the fraction of excreted sodium is greater than 2%. The kidneys are unable to concentrate urine, so their osmolality is actually less than 350 milliosmoles per kg. Causes of post-renal AKI could be happening within the lumen. It could be maybe a calculus or renal stones, blood clot, sloughed papillae, for example, in patients that are diabetic, analgesic abusers, those with sickle cell disease or sickle cell trait, patients with schistosomiasis, even tumors of the renal pelvis or the ureter or bladder tumors. It could be problems within the walls. It could be a pelvic ureteric neuromuscular dysfunction. This is a congenital and it's often 10% bilateral. It could be a ureteric stricture in the background of a TB, especially after treatment, or a calculus after surgery. It could be a ureterovesical stricture in congenital. It could be congenital. It could be a ureterocele. It could be a calculus. It could be schistosomiasis. It could be congenital megaureter, congenital bladder neck obstruction, and neuropathic bladder, urethral strictures. It could be in the background of a calculus, a gonococcal infection, even after instrumentation, or even a congenital urethral valve or a pinhole meatus. Or the obstruction could be coming from outside. It could be a pelvic ureteric compression, for example, bands or even aberrant vessels, tumors, diverticulitis, aortic aneurysms, retroperitoneal fibrosis, accidental ligature of the ureters on operation, quite common on C-sections, retrocaval ureters, right-sided obstruction. You may have a prostatic obstruction in terms of CA prostate and BPH, quite common conditions, and phimosis. Remember that screening for this obstruction may actually present in an acute fashion. For example, if this patient has a renal stone, they'll have this acute presentation, but most of these are going to be typically insidious in nature and rather gradual. Now, what are some of the common findings we see in AKI? So, patients may actually present with features of uremia. So, general features include nausea and vomiting, fatigue, weight loss, anorexia or loss of appetite, fetor uremeticus, which is this urine-like smell on the breath. They may have a metallic taste, hiccups, pruritus, uremic frost, quite something that you can actually pick up, muscle cramps, metabolic flap or hysterexis. Neurologically, they may have an encephalopathy with a change in mental status. They may have this intellectual clouding. They may be confused. They may be drowsy. They may actually even have seizures. They may actually be comatose. They may have decrease in memory and attention, and they may have some neuropathies. In the cardiovascular system, pericarditis and a pericardial friction rub is a very highly suggestive sign of uremia. Once you hear this and you see that urine output is reduced, prepare that patient for dialysis. They may have hypertension, volume overload, congestive heart failure, cardiomyopathies, hyperlipidemia, accelerated atherosclerosis. Hematological system, they may have anemia and bleeding tendencies because of the platelet dysfunction. So you may actually want to transfuse these patients with packed cells, transfuse them with FFP as well as platelets. In the metabolic system, they may have hyperkalemia, hyperphosphatemia, metabolic acidosis, hypocalcemia, secondary hyperparathyroidism, and osteodystrophy. I explained some of these complications towards the end of the lecture. They may have fluid overload. They may have, for example, pulmonary edema. This is an indication for dialysis. So this may be because of this salt and water retention, especially in those that you're trying to correct this hypovolemia and you give a lot of fluids without actually monitoring the status of this particular patient. They may have orthopnea, paroxysmal nocturnal dyspnea, peripheral edema. They have elevated creatinine and BUN in patients with AKI. Remember that severe infections may actually have initiated the AKI or have complicated it owing to the fact that patients with impaired immune system actually For example, even uremia causes an impairment in the immune system, and even just if there is improper management, things like insertion of a catheter that is not necessary, retention of this bladder catheter which is not necessary, they may actually be complicated by UTIs, complicated by bacteremias that can prolong the progress of acute kidney injury. Some of the cases may actually result in acute kidney injury. Things that may be suggestive of pre-renal failure, they may have intravascular volume depletion. Even on the history, they may have something that is suggesting that this patient has some massive losses of fluid. They may have orthostatic hypotension, a rapid pulse, poor skin turgor, features of dehydration and features of shock. They may have congestive heart failure. They may have a raised JVP, S3 heart sound, dependent edema, and pulmonary crackles. Remember that someone with AKI could either be hypovolemic, they can be euvolemic, and they can be hypervolemic. So they may either be in overload, they may be dehydrated or in shock, or they may have normal fluid volume. But in those that have hypovolemia, very important to replace the fluid. Those that have hypervolemia, very important to get rid of this excess fluid, because if you give them IV fluids, you worsen things. Then features that are suggestive of intrarenal AKI, they may have this oliguria with the brown granular casts, as well as elevated BUN and creatinine. They may have hyperkalemia because there's decrease in renal excretion, particularly following the trauma to the muscles, even in hemolytic states, with acidosis because you have decrease in excretion of these organic acids. They may have hyponatremia. This could be in the background if you replace the fluids using 5% dextrose. This, even over-enthusiastic replacement, can actually dilute the sodium concentration in the bloodstream. If you give them a lot of water, or they continue drinking a lot of water and they still have oliguria, you dilute the sodium concentration, they may have hyponatremia. If it's quite severe enough, they may actually even develop seizures. In terms of hypocalcemia, because the kidneys are not really producing the 1,25 dihydroxycholecalciferol, which is the activated form of vitamin D, so calcium also is not going to be reabsorbed. They may have some hyperphosphatemia due to phosphate retention, and proteinuria and hematuria. These are things that are suggestive of intrarenal AKI. Those that are suggestive of postrenal, remember you get this lower urinary tract obstruction, suprapubic pain, or a flank mass rather, with symptoms of bladder dysfunction like hesitancy, urgency. So what's our diagnostic approach? Remember here, your investigations are going to be aimed at determining whether this patient has an acute problem or they have a chronic uremia, or they have an acute on chronic presentation. Then you want to determine the cause of the uremia, whether it's pre-renal, renal, or post-renal, and also grade its severity. And you also want to determine the underlying cause, because your management is going to be targeted towards these things. So just a bit before I come to talk about the specific investigations we're going to do. So here, to determine whether this is an acute on chronic presentation, or acute or chronic presentation rather, you're going to want to take your history and the duration of the symptoms, do an examination, and previous urinalysis or even measurements of renal function previously can actually help. Remember that someone having these renal problems stemming back from 3 months back, most likely they have a chronic problem. Consider the following things. So remember that kidney injury in the hospital is going to be tied to another problem. Look for another problem. A patient cannot just come with kidney injury alone. There should always be something that is causing this injury happening. Look for an infection. Look for heart failure. Look for any medications that were changed. Is there any decrease or no urine output? Do they have any flank pain, edema, hypertension, or discolored urine? Is there any hesitance or frequency? Is there any weakness or easy fatigability that may be attributed to anemia? Is there any anorexia, vomiting, diarrhea, altered mental status change, even seizures or edema? Do they have any fever, cough, dysuria, or bleeding, like a melena or maybe hematochezia? Have they changed any medication recently? What new medication are they using? Do they have any medication, any chronic conditions that may predispose them to chronic kidney disease, like HIV, diabetes, hypertension? When you examine these patients, do your vital sign, include those that are going to be pointing out whether they have orthostatic hypotension, your BPs, your pulse. Tenderness, prostate examination, very important in males. So a rapid change of the serum, urea, and creatinine often suggests an acute process. Then if you get a normocytic normochromic anemia, it's going to be suggestive of a chronic disease, because anemia is actually one of the complications of pretty much the kidney issues. It may be because of the hemolysis, it may be because of the hemorrhage, it may be because of problems in production of erythropoietin from the kidneys, the peritubular interstitial cells. Get an ultrasound. The size can actually help you. If the kidney is actually small and have increased echogenicity, this is usually suggestive of a chronic process. Although the reverse is not really true. So the kidneys actually may remain even the normal size, even in patients with diabetes and amyloidosis that have kidney problems, the kidneys may actually remain the same size as the normal. Then you may sometimes get evidence of renal osteodystrophy, for example, digital subperiosteal erosions that may be due to the hyperparathyroid disease. These are usually suggestive of chronic kidney disease. Now, the question you must ask yourself, is this pre-renal, is this renal, or is this post-renal? Remember, bladder outflow obstruction is going to be ruled out if you insert a urinary catheter and you flush any existing catheter, which should be removed unless a large volume of urine is actually obtained. Any absence of the urinary tract dilatation on renal ultrasound, with actually very rare exceptions, is going to rule out urinary tract obstruction. So if you do ultrasound and you see that the calyces are not dilated, it's unlikely that there is an obstruction. So you should be able to distinguish between pre-renal and renal, to be specific. Here's a table, and I think I've talked about this in terms of the BUN, the urine sodium, the urine specific gravity, the urine osmolality, and even the fraction of excreted sodium. Though, like I said, this in clinical aspect is not so practical. Not so practical. Something that you can actually use practically is actually giving them a fluid challenge. If they improve, most likely it's pre-renal. You continue rehydrating them. If they don't, then most likely your cause is intrarenal. With obstructive causes, you'll be able to pick it up on the history and even when you do your physical examination. So you want to search for all possible etiologies of the AKI, including pre-renal, intrarenal, and post-renal disease. So what are some of the blood investigations you want to order? A full blood count. If there is a decrease in HB, suggestive of chronic kidney disease. If there is an increase in white blood cells, specifically eosinophils, suggestive of acute interstitial nephritis, or suggestive of an infection if there's an increase in WBC. A decrease in platelets could be due to a hemolytic uremic syndrome or a thrombotic thrombocytopenic purpura. Get your serum, urea, electrolytes, and creatinine, especially sodium, potassium, chloride, phosphate, magnesium, calcium, bicarbonate. Get your liver function test and liver enzymes. This could be a hepatorenal syndrome. Do your serum albumin, do your PT, PTT, and INR, for example, in DIC, in sepsis. These may actually alter the clotting times. Get your serum creatine and kinase if you're suspecting that there's muscles being broken down, a rhabdomyolysis. C-reactive protein may be increased in infections. Get your arterial venous blood gases, which may show in metabolic acidosis, blood cultures in cases of sepsis. Remember that even though creatinine is actually commonly used as a serum chemistry to evaluate patients that have AKI, there are actually other biomarkers that are still under research that actually can even be elevated even before creatinine is actually elevated. And this could potentially be used in future to test for AKI. Things like neutrophil gelatinase associated lipocalin. This can be measured in the plasma, it can be measured in the urine. For example, kidney injury binding protein 1 or the KIM1 or the retinal binding protein, cystatin C, even alpha or even beta macroglobulin, urine uromodulin. These can actually be used, though most of these biomarkers are not used widely and they haven't yet been validated by wide-scale studies, so we rarely use them in our clinical practice. You also want to get some urine studies. Do a urinalysis. If there's trace or no proteinuria, suspect pre-renal and post-renal causes. If there's mild to moderate proteinuria, suspect ATN, acute ATN. If there's moderate to severe proteinuria, suspect glomerular disease. If there are white blood cells, maybe this could be a UTI. Maybe it's an acute interstitial nephritis. Remember, hematuria and proteinuria could be in the background of glomerular nephritis. It could be stones. It could be UTIs, tumors, trauma. Blood is if the blood is microscopic, it could be suggestive of acute interstitial nephritis. Do your microscopy. Remember here, in patients with glomerular nephritis or rapidly progressive glomerular nephritis, they may have red blood cell casts in glomerular disease. Then, of course, they may get some formed elements or hyaline casts. These are suggestive of pre-renal and post-renal failure. You may have crystals of red blood cells and white blood cells in post-renal AKI. And many red blood cells usually are suggestive of trauma, suggestive of infections, suggestive of tumors, and even calculi. If you get eosinophil casts, which are seen in 95% of patients that have allergic acute nephritis, and sometimes you may even see neutrophils. The brown granular casts or tubular epithelial cellular casts, these are often seen in acute tubular necrosis. Do your urine cultures if you're suspecting that there is signs of infection. Do your urine chemistry, your urine sodium, of course, calculate your fraction of excreted sodium, calculate your urine osmolality. You may also order for serum and even urine protein electrophoresis, that's the SPEP and the UPEP, to rule out any monoclonal gammopathies and even multiple myeloma. In terms of radiography, you want to get an ultrasound to check the kidney size and the shape, and also detect any hydronephrosis, dilatation of the calyces, or the hydroureter. It's also going to help you pick out pathologies like renal stones and even renal vein thrombosis. You can do a retrograde pyelonephrogram. This is done if you're suspecting there's an obstructive uropathy. An abdominal X-ray, an ECG that may show features of increased potassium. I'll talk about these at the end. Chest X-ray that may show pulmonary edema or other systemic diseases. You may also do an abdominal CT. And like I told you, those that need contrasted studies, for example, if a patient has AKI and they have an MI and you want to do an angiogram, you have to weigh the risk versus benefit. So if this patient is at risk, or rather has more benefits in helping you, maybe it's an intervention that you're going to be instituting, or you need this to make a diagnosis before you treat this patient, make sure you hydrate your patient before and after the procedure, because this may sometimes even dilute the contrast and prevent the contrast-induced AKI. In some cases, you may need to do a biopsy. So what are these cases? If there's suspicion of rapidly progressive glomerulonephritis, if there's prolonged acute tubular necrosis that has not recovered, less than 3 weeks, if there's no cause that has been found in terms of AKI, you want to biopsy them. And remember that this test is going to be associated with increased risk like bleeding and should be done with caution in those patients that have a solitary kidney or those that have coagulopathies present. Remember that the markers such as, like I told you, fraction of excreted sodium, urea, and urine osmolality, they can be helpful in determining pre-renal, infrarenal, and even post-renal, but they can be affected widely by many drugs. And in clinical practice and not so much diagnostic, we actually quite ignore them most of the times. There is no single marker that can be used to say this is a single marker that is pointing towards AKI, so make sure you tie everything into your clinical picture. Most of the times, the time of onset of AKI is quite useful when you're dealing with hospitalization of patients. So if you get a sudden rise in the creatinine, an inciting factor usually would be something that happened in the past 24 to 48 hours of this patient. So look for anything that is out of the ordinary. Did this patient receive any radiological contrast? Maybe this could be a contrast-induced AKI. Has this patient been started on any new medication? Have they been started on any ACE inhibitors, any ARBs, or any other drugs that could contribute to AKI? Now, the most important bit of this particular lecture is this bit that I'm going to talk about, the last part, which is the management. Because here, if you don't manage your patients very well, they will lose their kidney function. If they lose their kidney function, they may die. Some of these complications, very deadly, they will die. So whenever someone has reduced urine output, the first instinct that you must always have as a doctor is to first check the catheter. Check that the catheter is inserted correctly, because sometimes it may have been inflated in the wrong place. It may be wrongly put. You may find out that they haven't connected it so well and it's blocked. If the catheter is not functional, try and flush it or try and change it if need arises. Then if the catheter is well and there's still no urine being produced, then you should exclude any reversible cause like an obstruction, relieve any obstruction. If there's an infection, treat the infection. Continue good nursing and physiotherapy, regular oral as well as chest physio and toiletry. Do your input-output charts, strict input-output charts, because you don't want to be overloading this fluid with a lot of patients, or rather you don't want to overload this patient with a lot of fluid. Sorry, I think I am exhausted. And you also want to monitor and maintain the urine output. So remember, although of prognostic importance, oliguria is actually debated. Then management of patients that are actually non-oliguric is actually much easier than those with oliguria, because here there's a bit of a challenge in terms of how much fluids are we going to give. How long should we wait? Should we take the patient for dialysis or not? Daily weigh your patient, because rapid changes in the weight gain is a good indicator of renal as well as even cardiac function. Patients should be confined to bed only if it's necessary or essential. They should avoid certain drugs, and I just want to spend a bit talking about the drugs because this is very important. Loop diuretics, beta blockers, ACE inhibitors, ARBs, aminoglycosides like gentamicin, streptomycin, amphotericin B, penicillins, sulfonamides, NSAIDs, corticosteroids, penicillamines. These are drugs that can cause damage to the kidneys. You want to stop the NSAIDs because they're going to be causing vasoconstriction of the afferent arteriole. They're going to be causing damage to the glomerulus. ACE inhibitors will reduce the pressures, effective pressures in the glomerulus by causing vasodilatation of the efferent arteriole because they block the effects of angiotensin. The nephrotoxic antibiotics like aminoglycosides, vancomycin, piperacin, tazobactam, amphotericin B, tenofovir, and even nephrotoxic chemo drugs must be stopped. The drugs that are cleared by the kidneys should be switched to other drugs that are cleared by the liver. And remember, there are some drugs that can accumulate in the bloodstream because they're cleared out by the kidneys. So these should either be substituted or the doses actually be regulated. So these are drugs like metformin, gabapentin, cefepime, morphine. You want to switch them to drugs that are not renally cleared. You want to review your medication chart and make sure that you adjust the dose appropriately. One mistake that most people make in clinical practice is that they use what is known as the estimated GFR to actually modify the dose of certain drugs. So they use a certain formula that is known as the Cockcroft-Gault equation, and this is calculating the creatinine clearance, where they say the age 140, or rather 140 minus the age of the patient, multiplied by the weight divided by the serum creatinine. If the patient is female, you multiply this by 0.8. Now, this formula here, what you need to note about this formula is that, number one, it's greatly affected by the level of creatinine. So it means that if someone has an AKI and the creatinine suddenly rises or the creatinine suddenly falls, if the creatinine suddenly rises, you may actually overestimate the GFR and you may not actually renally modify those drugs that you're giving this patient. If the GFR suddenly falls, you may underestimate the GFR and then reduce the dose of the drugs, and you're underdosing your patients. So a better way to actually calculate, and I want you guys to actually look this up, is known as the kinetic GFR, which is going to be taking into account the current creatinine level, the previous creatinine level, the time duration between these changes in the creatinine readings, and the age and weight of the patient. You should use the kinetic GFR to actually modify the drugs that this patient is actually taking. You want to avoid intravenous cannulae, bladder catheters or other invasive devices that are unnecessary to prevent infection. Make sure that they have adequate calorie intake. This is essential for patients with AKI, so the diet should reduce in proteins but contain carbohydrates. So the protein requirement is roughly about 0.8 to 1.2 grams per kg per day. The route of administration is preferably you want to give them enteral by mouth, even by NG tube, or even parenteral if things are just bad. So this should be the last option. It's only necessary if the patient is vomiting or has some bowel dysfunction, which is rendering the enteral route inappropriate. Give them some vitamin supplementation. Fluid and electrolyte balance, I will come to talk about it very shortly. Very, very important, the cornerstone management of this condition. And you manage the complications as they come: pulmonary edema, anemia, sepsis, metabolic acidosis, electrolyte imbalances, and GI bleeding. So remember, this I've already talked about in terms of iodinated contrast. Make sure you rehydrate your patients before the procedure and rehydrate them after the procedure. If all measures actually fail, you want to give them renal replacement therapy, which is in this case dialysis. So you want to replace the function and wait until the kidneys have regenerated and they have repaired to restore the normal renal function. It could either be hemodialysis or even peritoneal dialysis. Generally, both actually appear to be quite effective in the management of AKI. Things that are absolute indications: signs and symptoms of uremic syndrome, they need dialysis. Hypovolemia, which is refractory to treatment, they need dialysis. If they have severe hyperkalemia or hyperkalemia with symptoms, they need dialysis. If they have metabolic acidosis with other significant things that I'll talk about, they need dialysis. So you can remember the indications of dialysis as the vowels R, A, E, O, U, A for acid-base balance or acidosis, E for electrolyte imbalances, especially with hyperkalemia, where they may have nausea, weakness, vomiting, palpitations, and some ECG changes. I'll talk about those very shortly. Intoxication in terms of methanol, ethylene glycol, lithium, salicylates, overdose or rather overload of fluids in terms of pulmonary edema, uremia in terms of, or U in terms of uremia. They may have pericarditis, a pericardial rub, encephalopathy, severe bleeding. Now, how do we manage patients when they come in the emergency department? So remember that many cases are actually going to overlap between pre-renal as well as acute tubular necrosis. So best way to determine whether this is pre-renal or it's not is give them a fluid challenge. If there's no contraindication, meaning they have no features of overload, volume overload, they have no crackles in their lung bases, their BPs are not increased, they don't have any features of peripheral edema, they don't have any gallop rhythm or auscultation, their JVP is not raised, meaning that they have no features of fluid overload. They are not in distress, they don't look puffy, the face doesn't look puffy, the eyelids don't look puffy. You may consider giving them a fluid challenge. So this is going to be requiring you actually monitoring the urine output of this patient and the renal function. And if the renal function improves with your fluid challenge, this is very highly suggestive that this patient has a pre-renal AKI. Because remember that with acute tubular necrosis, as well as other intrarenal causes, they often take some time to recover. They may take even weeks or even months to completely recover and retain the renal function. Diuretics actually may be required during the oliguric phase of ATN if these patients are hypervolemic, they have a lot of fluid overload. You want to get rid of that excess fluid because it may cause problems if the patient has pulmonary edema, for example. So in the fluid challenge, if they're dehydrated, you can give them 250 to 500 ml of saline over 30 minutes. Then you can repeat the challenge if they're still dehydrated and then assess if there's a good effect. If their BPs are greater than 100 millimeters of mercury, a better way to actually be checking for central venous pressure. But sometimes this may need an invasive procedure and you want to avoid that. So you can have a MAP greater than 65, a mean arterial pressure. So caution should be given in those that have cardiac dysfunction, those that are known heart failure patients. Give this with caution, the fluid challenge. Listen to the lungs and assess for fluid overload. Check for signs of fluid overload, increase in BP, increase in JVP, lung crepitations, peripheral edema, gallop rhythm on the cardiac auscultation. Like I said, central venous pressure measurement is going to be used to monitor the fluid status. Once the fluids have been replaced, you continue them at 20 ml plus the previous hour's urine output per hour. So in terms of what fluid are we going to give? Bit of a debate here. So there are some studies that actually suggest that balanced crystalloid solutions, that's lactate, Ringer's lactate, and Plasma-Lyte A, actually in the emergency department should be used in these patients with AKI as opposed to actually using isotonic solutions like normal saline. And this normal saline was actually associated with increase in renal, or rather reduction in the use of these balanced crystalloids is associated with reduction of mortality and reduction of AKI or renal-associated complications. These were findings that we're seeing from the SALT-8 study as well as the SMART study. So what you want to do is you want to assess your patient and determine whether they are falling under one of the three things. Whether your patient is hypovolemic, they could have a background of diarrhea or vomiting. You want to assess whether they're hypervolemic if they're having heart failure or hepatorenal syndromes or even liver cirrhosis. So you want to assess if they're euvolemic. So remember that if you're giving these patients fluids that have sodium or ammonium chloride in them, these are going to cause vasoconstriction of the renal artery. They may actually even decrease the renal blood flow, and they can actually decrease the GFR. This has been noted to be seen in rats. It was noted even in dogs. Similar effect actually happens even in humans. So this is because of the hyperchloremia. So this effect, or the effect's actually not similar with infusions of smaller volumes, and this is often actually seen with those patients that receive large volumes. So even those patients that have fluids that have sodium bicarbonate, sodium or even ammonium acetate or even dextrose, we don't see this effect. But in the majority of the patients who have normal kidney function and they're not hyperchloremic, they don't have sepsis, and they only require modest amounts of intravenous fluids, you can use isotonic saline. You can use normal saline as a reasonable thing. But those that have higher risk, like those that have sepsis, those that have AKI, you want to use your balanced fluids. Research has actually shown this. So in patients with metabolic acidosis, fluids, even with a higher bicarbonate concentration, should be indicated. Then if you assess the patient, for example, when you find out that JVP is reduced, the skin turgor is poor, Capillary refill time is low, BPs are very low, MAP is low. You give them 1 to 3 liters of a buffered crystalloid, which could either be Ringer's lactate or Plasma-Lite A. You're going to be giving it at a rate of 75 mils per hour. You should note that fluids with high concentration of chloride are going to increase the risk of hyperchloremic acidosis. So fluids like normal saline will increase the risk of hyperchloremic acidosis. You want to avoid any artificial colloids like destron. You also want to assess the patient. If the patient fails to respond, usually this means that the cause is acute tubular necrosis or there is some intrinsic AKI that is there. If the BP still remain low in this patient, you want to consider giving them a vasopressors like norepinephrine. If you assess them and you see that they're hypovolemic, for example, they have increased JVP, crepitations in the lungs, a gallop rhythm, you want to restrict the salt intake, give them a trial of loop diuretics. So you may give them high-dose loop diuretics starting from about 80 milligrams of Lasix. If they fail to respond, take them for dialysis. A good response, once you give them the 80 milligrams of dialysis, in the next 2 hours, they must produce at least above 200 mils of urine. If you assess them and they're euvolemic, you can also consider giving them a fluid challenge and assess the response. Twice daily clinical assessment is needed for these patients, and in general, once the patient is euvolemic. So the daily fluid intake should be equal to the urine output plus the insensible losses of about 500 mils per day. And then this should also take into account fluid losses from the fistulae and even from vomiting. Those patients that are febrile are losing extra fluid, so you should actually account for that in your fluid balance charts. If there's abnormal loss of fluids, like for example, the sustained diarrhea or abnormal fluid or electrolyte losses, then you must add these things to their fluid regimen. If they develop signs of salt and even water overload, like peripheral edema, basal crackles, elevation in the JVP, or if they have hypovolemia, then you should reassess their fluid charts. So remember that large changes in the weight of the patient are going to reflect as changes in the fluid balance, and they should also prompt you to reassess the volume status of this particular patient. Now, in management of the complications of AKI, in patients that develop hyperkalemia, remember there's a concentration of a serum concentration of potassium greater than 6.5 and without symptoms, or if it's greater than 5.5 with symptoms, they may have cardiac dysrhythmias like ventricular fibrillation, they may have some neurological complications, and some of these ECG findings like peaked T waves, this is best seen in the precordial limbs, they may have shortening of the QT interval, sometimes ST segment depression, even widening of the QRS complex. Once you see this, restrict the potassium intake to less than 2 grams per day. Stop any fluids that have potassium in them, discontinue any ACE inhibitors if they're on, protect the heart. So the first step is to protect the heart. Give them calcium gluconate, 10 mils of 10% over 5 minutes. Push the potassium into the cells. Give them glucose solution, 50 mils with or 50% dextrose with 10 international units of insulin as an infusion. Then excrete the potassium. You could give them potassium-binding ion exchange resins like kayexalate. If all these medical therapies actually fail, you want to take the patient for dialysis. Then those that have pulmonary edema, restrict any salt and water intake. Try diuretics, 80 to even as high as 200 milligrams of Lasix. Then you want to monitor for increase in urine output. And output, like I told you, greater than 200 in 2 hours is quite adequate. If there's no response, refer them for renal replacement therapy. That's your dialysis or hemofiltration. If they have a sepsis, remember infections, when present, should be treated. Bear in mind you don't want to use any nephrotoxic drugs. Avoid or actually even monitor the levels of drugs like gentamicin, vancomycin, penicillins, and sulfonamides. Prophylactic antibiotics or barrier nursing is actually not recommended in all the cases. In terms of hyperphosphatemia, remember this is often going to be controlled by restriction of the dietary phosphate and by oral aluminium hydroxide or calcium carbonate, which actually reduce the gastrointestinal absorption of phosphate. So daily ingestion of potassium and phosphorus should be monitored. Remember, sodium and potassium intake should be minimized. Restrict the phosphate to less than 2 grams per day. And if you measure the concentration of phosphate and it's greater than 5.5 milligrams per deciliter, you may give them phosphate binders. Remember, most of the times, high levels of phosphate are often associated with low levels of calcium, so patients may actually even have this tetany, they may have these spasms. So if the calcium, you measure the calcium and it's low, you can give them calcium acetate or calcium carbonate. If the calcium is high, you may give them sevelamer, you may give a lanthanum, you may also give them aluminium hydroxide. In terms of metabolic acidosis, often we don't treat it unless if the concentration is less than 15 millimoles or the pH is less than 7.2. In the mild cases, we may actually consider giving them bicarbonate tablets. But if they have severe cases, we actually want to correct this using IV sodium bicarbonate. And remember that the initial rates of replacement are going to be guided by the bicarbonate deficit and should be adjusted according to the serum. But your target is to get the bicarbonate between 20 to 22 milliequivalents, and your goal is a pH greater than 7.2. So you can administer 3 ampules of sodium bicarbonate, that's about 150 milliequivalents, in 1 liter of 5% dextrose, and you give this slowly because it's a very huge infusion. Remember that bicarbonate is associated with hypervolemia, metabolic alkalosis, hypocalcemia and hypokalemia. So you want to actually check for these electrolytes and continuously do your ABGs. In a practical point of view, patients that are going to require bicarbonate, within a few days, you see that patient actually needs emergency dialysis. If they have anemia, transfuse them if it's severe, or if recovery is delayed, and you want to give them packed cells because you want to prevent that excess fluid or overloading them with that excess fluid that you get with whole blood. If they have a GIT bleeding, remember you want to give them regular doses of antacids, which are going to reduce the risk or incidence of GI hemorrhage significantly and may be more effective in this regard than the H2 antagonists or even the proton pump inhibitors. So here's a summary of the checklist in patients with AKI. So you want to confirm the diagnosis and stage the AKI, get the labs, FBC, a blood metabolic panel, calcium levels, magnesium, ABGs or VBGs, urine studies, get a urinalysis, urine microscopy, urine chemistry, get sodium, urea, osmolality, and even creatinine. Consider urgent ultrasound and a Foley's catheter placement if there is suspected urinary tract obstruction or if the catheter is blocked. Consider consulting nephrology quite early. Assess the volume status, whether they're hypovolemic, euvolemic. Optimize their volume status. Identify and treat any complications like acidosis and hyperkalemia. Identify and treat any underlying causes. Hold any nephrotoxic drug and renally adjust other medication. Remember, you want to use your kinetic GFR. You also want to provide additional support, nutritional support, prophylaxis against venous thromboembolism. Remember that, again, patients with uremia are at risk of bleeding. So these you want to avoid giving them those low molecular weight heparin because if they have uremia and you give them that, they'll bleed. Complications of AKI include intravascular overload. This may be recognized by rapid weight gain, hypertension, elevated central venous pressure. There may be a raised JVP, pulmonary edema. You may have electrolyte imbalances, hyperkalemia, serum potassium greater than 5.5. This is because there is less potassium being excreted and also cells are being killed off. Cells are bags of potassium. They release this potassium. Hemolysis is happening. Hyponatremia, serum concentration less than 135 milliequivalents per liter. This is because of excess water intake in the background of someone having excretory failure. So it's a dilutional type of hyponatremia. All patients that receive 5% dextrose. Hyperphosphatemia, serum concentration greater than 5.5 milligrams per deciliter because there's a failure of excretion or tissue necrosis. Hypocalcemia, serum concentration less than 8.5 milligrams per deciliter, maybe because there's a failure in activation of vitamin D. Maybe there's a hyperphosphatemia or hypoalbuminemia because as necrosis is taking place, calcium is depositing in these dead tissues and it's being used up. Hypercalcemia, serum concentration of calcium greater than 10.5. This happens usually in the recovery phase following rhabdomyolysis induced by acute renal failure. Metabolic acidosis, because of failure of excretion of those organic acids as a pH less than 7.35, it's often associated with sepsis and even severe heart failure. Hyperuricemia, because there's decreased uric acid excretion. You may have bleeding tendencies, which may be due to platelet dysfunction and even coagulopathy-associated sepsis. Seizures that may be occurred to uremia and even chronic renal failure if the initial thing has not been addressed. In terms of prognosis, remember that mortality rates among patients with AKI is approximately 50. It should be stressed, however, that these patients usually are going to die as a sequelae from primary illness that has induced the AKI, and they won't really die because of the AKI itself. The mortality is going to be actually affected by underlying disease. And in clinical setting of patients with AKI, for example, mortality rate of acute tubular necrosis is 60%, when it's actually resulting from things like surgery or trauma, and 30% when it's actually occurring as a result of medical illnesses, and 10% or up to 15% if it's resulting because of pregnancy. The mortality rates are higher in older individuals because they're going to be much more debilitated and they're going to have associated multiple organ failure. And remember that patients with no complicating factors who survive in episodes of AKI are actually at 90% chance of completely recovering their renal function, which is why you must intervene quite early. I really hope you enjoyed this blockbuster lecture on acute kidney injury. If you did and now you understand about acute kidney injury, please don't forget to drop a like, drop a comment in the section below. To Zambia and beyond. By the time I upload this video, I know we would have reached 18,000 subscribers. So a big shout out to each and every one of you guys. We'll see you next time. Until next time, my name is Dr. Moses Kazevu. Bye-bye.